They can hear us?
Okay.
Okay.
We can't hear anybody, but I'm excited to be accompanied by Dr. Mohammed Alhaddad. We are in the midst of a poem for type 2 achalasia, and I'll have him sort of go over what he's done so far and where we are.
Thank you, Dr. Ahmad. Welcome, everyone. We're here in the tunnel. Actually, we took the liberty to do the incision approximately 10 centimeters above the LES, and took the time to do a little bit of tunneling before we came live. And here we are, almost at the level of the LES. I'm going to handle this little oozer here with just a touch of precise sect. That's my preferred modality for dissection. But let me kind of bring you out and show you what we did. So this achalasia comes with a slightly dilated esophagus. As you can see, typical stasis changes in the mucosa. Not a sigmoid esophagus yet, but patients had symptoms for 7 years before the motility test confirmed the achalasia. A little bit of a tight LES, however, there's no other pathology that we saw distal to the GE junction. So we took the liberty to go ahead and get the tunnel going on the posterior side, approximately 10 centimeters above the LES. And here's the tunnel. As you can see, this looks very dysfunctional type of musculaires. As you can see, all these frequently bumpy, ringy type of musculaires typically is seen in esophageal distal motility. Here we start to get, the field gets a little bit tight as we get close to the LES. So we're trying to get, carefully dissect closer to the muscle layer, away from the mucosa, to prevent any muscle injury. We're working with the Fuji system here, and this is a hybrid knife, which the T type of the hybrid knife, which allows injection and allows cutting at the same time. When I don't see vessels, for efficiency, I actually use the cut mode to advance myself. When I see vessels, I usually switch to precise sect. I know some people still like force coag as well in this location for dissection. I think for efficiency purposes, you can, once you have the confidence, you can definitely utilize the cut mode more frequently to enhance your efficiency. Our goal today is to get past the LES and into the GE junction. We don't need to advance it more than 3 centimeters into the cardia, just enough. I'm trying to widen the tunnel here a little bit, just enough to get us into the gastric side and allow us to do the myotomy. Okay, so just again, this is kind of the slow, predictable part of the procedure here. And I can tell you this looks like it's part of the LES complex. Yeah. It's pretty tight. You can see the what I call the ridge or the shelf sort of configuration. And usually the field tightens up quite a bit. This is where you need to spend a little bit more time. That's what I like about injecting as we go along. Typically that would allow you to get through with minimal, hopefully minimal mucosal damage or muscle injury. I don't know if we have any questions from the audience so far. Huh?
I hope you guys can hear and see us, but we're happy to answer any questions from the audience or the moderators. We're making our way through to the LES, which is at about 36 or 37. And you guys can see here that it's getting a bit tighter. The vascularity increases, and so you know that you're approaching that area.
Yeah. So here's the LES. Clearly this is the top part of the LES. I think beyond that, we are going to get into the cardia. This is the aberrant muscle fiber we see in front of us. It's common that around the LES with achalasia, you see these aberrant fibers crisscrossing and kind of going into the submucosal layer. See how wider it is right now? So I'm going to take the chance to ride the wave and dissect. If I'm not seeing any vessels, I'm going to go ahead and just cut through some of the submucosal fibers here. And this one will require a little bit of precise sect, but this looks like, to me, this is all cardia. And we can confirm now by injecting because see how tight this is? This is
Yeah.
all LES. Beyond that, it's all cardia. And you can see the spindle veins, which is typically a very pathognomonic finding of the cardia. We will cut just a little bit more. And let's see.
So options to figure out where you are and whether you're at the LES is, like Dr. Haddad said, is to inject. I know some people will take just pure methylene blue with a needle injector and put it at the most distal point and then retroflex. I know historically people used to use XP scopes and go down to look
Correct.
at the light source as well. But you know, with the dye, I think that's probably more than enough now to know that you've gone beyond where you want to go and into the cardia.
Here's the arterial bleed. See, it's pulsating. At this point, we have two options. Either we can just be a little bit patient and you know, just tamponade it with the disc. That's why I like the T-knife. The disc gives you a lot of physical pressure that you can tamponade with, or you can grab your coag grasper at that point. For now, I think we might be okay. Let's see if we have blue crossing over to the gastric side. This is all blue posterior, as you can see. Blue, 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 and then I'm going to pull the needle back just to knife a little bit so I'm not bending it too much. And you can see there's quite a bit of blue also on this side. You can argue we can go a little bit further, but I don't think going any further in the cardia is going to really yield a whole lot of benefit at this point. What do you guys think? Is it convincing enough for a lift on the other side of the LES?
I think this looks quite good for me. I think you have a nice submucosal tunnel into the cardia.
Just suction, and if we have a consensus, we can actually start the myotomy. The myotomy in type 1 and type 2, as of recent data that showed there's no benefit. In fact, you might have more reflux with short myotomy, with the long myotomies. There's even some consensus now that even type 3 achalasia could benefit from a limited myotomy. We can argue about that, but definitely for type 1 and type 2, the myotomy usually is between anywhere from 5 to 7 centimeters. No more than that is needed. And we know this is the LES right here. So this is the crux of this, or you know, the success of the procedure hinges on cutting the area that I'm looking at right here for the next 2 to 3 centimeters. However, I'm going to go ahead and add another centimeter on the esophageal side and maybe 2 more on the cardia side. Can we switch to spray? Oh, sorry. Yeah, I like spray coag. It does tend to lend to a very efficient, 4.5, please. It lends to a very efficient and quick cautery of those oozers that come between the muscle, the longitudinal and the circular. Thank you. And usually I use the cut mode. Again, I think it's just more efficient to cut and only use the spray when needed. So far, I'm not getting to the circular muscle fiber, to the bottom, but I think there we go. Longitudinal circular junction is in front of us. We are going to, at this point, just carry this forward.
So this is oftentimes where I'm telling the fellow or whoever's with me in the room to do, you know, crepitus checks on the neck, check the abdomen. Anesthesia is usually cognizant that the CO2 tends to rise. The peak pressures may change. And this is all part of the process because we're not going full thickness and air is expected in the mediastinum.
Correct. This is a time to also be, at my institution, I would use a low flow CO2, so we're not using a standard flow. And you may think that this doesn't look full thickness yet. It's okay. We can come back and clean it up and make it full thickness, especially in the LES. However, as Dr. Ahmad said, this is not a good time to do a full exposure of the mediastinum. I can afford to do that late in the game, but I don't want to do it early in the process because often this is when you end up with pneumomediastinum. And the other part I do sometimes, if I feel like I need to build a cushion, is I can inject between the muscle layers and create a kind of a buffer, and then cut right above that if I have any doubt that this is going to be, there's any bleeding going on. Here getting almost a full thickness.
And so I noticed, Dr. Haddad, you started your myotomy always proximal, like as proximal as can be, and work your way down. Is there a reason behind that? Do you ever start at the LES and work your
Yes.
way down?
Actually, there's no really science to this whatsoever. It's just a habit. If you are someone who likes to, antegrade rather than retrograde, I'm going to show you this vessel here between the muscles. And this is actually a great one to remedy with a quick burst of spray coag. And also the margins of the myotomy sometimes bleed, and this is a good time to use that. See how thick the LES is. Everything above my knife here is essentially, there's a little bit of an ooze here. Let me go ahead and, but everything above the knife here is a very dysfunctional, very thick. And the best way, I think, is just a few bursts of cut mode. And come back and do a little bit of extension of that into the cardia. We're making very good progress on this myotomy. What do you guys think?
Yes, absolutely. And so some people will do a pre-cut myotomy when they're struggling to really get beyond the LES. Is that something that you ever do?
Yeah, intermuscular dissection and pre-cut myotomy is something with severely fibrotic. 1 minute? Okay. So yes, sometimes that would be something you would do if you are really about to abort and you just don't find a way forward.
Yeah.
That might not be a bad choice to salvage the procedure where you do pre-cut or superficial myotomy just to get through the LES. Okay, let's see that, this is almost looking like a decent full thickness at this point. We can come back and clean some of these crisscrossing fibers. Just making sure we...
Mr. Haddad, just to confirm the good myotomy extension beyond the lower residual sphincter, do you use a double scope or just the light of the scope or the stain of the methylene?
Honestly, I use a stain mainly. And at this stage, we have identified the morphology of the GE junction and the LES quite confidently based on looks alone. And I can tell you that this is all cardia. I probably don't need another scope to tell me that that we're well past the lower end of the LES. So it's essentially I'm going to just do one final cut here to get to the end of the tunnel if I can. And now I'm going to just give this a minute, maybe come back and see. Yeah, so usually... Oh, thank you so much. Yes.
Thank you. We might be done by then, though.
Yeah, we'll be